This is what I really want to impress on you is ongoing screening for kidney and bladder function. So this is annually. What you could do is order labs. We ask for eGFR, creatinine, and the new lab is the cystatin C to show bladder kidney function. Secondly, what's easy to get is a renal ultrasound. They'll check for the kidneys and bladder to rule out hydronephrosis and bladder stones. And then lastly, for complicated, recurrent urinary tract infections, we ask that you refer to urology. Actually, you should refer to urology on an annual basis. They just need to see and talk to a urologist, and then the urologist can triage if they need a cystoscopy or urodynamic studies. So cystoscopy, we normally do this 3 months after the initial spinal cord injury just to get a baseline study. And then what it is really good for is to evaluate the anatomy. It's a camera through the urethra into the bladder. They look at the bladder wall and look for tumors and stones. The frequency, again, the guidelines keep changing, but if somebody has complications with their neurogenic bladder, I would recommend an annual screening, and then especially if they have an indwelling catheter, such as a Foley or suprapubic catheter, they should be getting the cystoscopy once a year. Complications, there are a lot. Bladder and kidney stones, some people are just stone formers. We haven't figured out how. They could be the greatest water drinkers, but they form stones. So it's really important to, review diets with them. Second is urethral erosion. There's something called traumatic hypospadias, which you can imagine just splaying the urethra through the penile tissue. Urinary tract infections, which I'll go into in depth later, and then epididymitis. Incontinence, there's bypassing of the urine. Hydronephrosis, it sounds contrary that if you have a Foley catheter, it should be always draining, but sometimes the bladder can spasm enough that it increases the bladder pressure to lead to hydronephrosis. Over decades, there's a lot of fibrosing and scarring that happens in the bladder, and you could see this is a fluoroscopy of a Christmas tree bladder because it's so fibrotic that a lot of what's left is just the trigone, and then you could see the diverticula pooching out here. And then bladder cancer, and it's not the typical transitional epithelial, it's squamous cell carcinoma. This should be a discussion for people with indwelling catheters, the risk of bladder cancer. It does and can happen with prolonged, decades-long use. But again, the demographic of our patients, it's bimodal. We've got the young men who have injuries, for decades thereafter. And so if they are tetraplegic and they need an indwelling catheter, this is a real risk for them. It is super important just to get the cystoscopy done with indwelling catheters. And then the indications, the urologist will want to know if there's ongoing hematuria with recurrent urinary tract infections. It irritates the bladder wall. Hematuria is one of the manifestations. Again, recurrent UTIs. Asymptomatic bacteria, I can't say it, sorry, from stone-forming organisms. Proteus is a huge one. And then anytime you have sepsis with pyelonephritis, warrants a referral to a urologist. And then even if somebody has been using an indwelling catheter and they have recovered hand function and want to trial clean intermittent catheterization, this is a good time to send them to a urologist. And then the second study, which is really important to help us identify the best bladder management strategy, is a urodynamic study. And this is when they go to the urology clinic. There are catheters that fill the bladder with saline, and then they check the pressure in the rectum, which is the abdominal pressure, and then the pressure in the bladder, which is the vesicular pressure, and then they get the difference and find the detrusor pressure. Why this is important? Bear with me. So the detrusor is really magical in that the ureters, when they enter the detrusor, comes at an angle. So as the bladder fills, the valves close, and that protects the ureters from backflow. But it could only withstand so much pressure. So if you go beyond 40 centimeters of water over years, those valves become incompetent, and then that leads to reflex. So this is the only study that helps us to understand the pressures within the detrusor. And then lastly, for upper motor neuron bladders or the spastic bladder, we do use a lot of medications like antimuscarinics, old school oxybutynin, tolterodine, Vesicare, and then alpha-1 blockers. This is usually for those who say, they have a hard time starting their stream. So we'll use tamsulosin. The newest one is mirabegron. It's a beta-3. Fewer side effects of like dry mouth and constipation, but it is quite expensive if people don't have coverage. And then lastly, Botox. Botox is really, really good for bladder spasms. It lasts for 6 months. They use 200 units of Botox, and we could also use Botox for muscle spasticity. And then we just work with the urologist to make sure we don't go over the recommended dose. And then I just put a note at the bottom that the alpha-1 agonist can cause hypotension, so I tend to give it at night.